All right. Good afternoon and welcome to the Iowa Cancer Consortium's Capacity Building Series webinar entitled Exploring the From Cancer to Health program. My name is Allie Bain and I'm an outreach specialist for the Iowa Cancer Consortium. More information about the ICC and its partners and programs is available online at www.canceriowa.org. This webinar is one of a series of webinars meant to increase knowledge among the ICC's members and partners. The webinar is being recorded and will be available on canceriowa.org. We hope that you enjoy today's content. Before we get started, I just want to walk everyone through a couple of the webinar features. You will be in listen-only mode, so you'll be able to listen through your computer speakers. In the upper right-hand corner of the screen, you will see the attendees list. So if you would like to private chat with anyone, you can hover over their name and select Start a Private Chat. In the bottom right-hand corner, you will see the chat box where you can interact with others and ask questions to the presenters. We will save the questions until the end of the presentation, but you can certainly type them in as we go. If you're having any technical difficulties at all during the webinar, please indicate so in the chat tool, and I will work with you to resolve them. And now let's go ahead and get started. So while I introduce our presenter for today, if you guys all want to take a second and type in your name and the organization that you work with. So today our presenter is Erin Sullivan-Wagner. Erin is a certified life coach and works with coaching patients in the CanCare organization, specifically with sexual dysfunction due to treatment. She also works with providers as a consultant to help them better work with patients who are having sexual dysfunction issues related to treatment. In August of 2013, Erin attended the From Cancer to Health Institute at Ohio State University and is here to share some information about that with us today. Erin herself is also a 6-year cancer survivor from anal cancer. All right, Erin, are you ready to rock and roll?
Hello, yes I am. Can you hear me?
Yes, I can.
All right. Well, welcome everybody. Thank you for joining us today. The topic today is managing the stress of a cancer diagnosis and treatment, and the program I'm going to be walking through with you is From Cancer to Health. So the purpose of the Cancer to Health intervention is to reduce the stress of a diagnosis and treatment and enhance a patient's ability to cope and recover as they move forward. Though cancer is unique to every person, we understand that all patients would describe this cancer experience as a very stressful one. Though we may have other stressors in our life before cancer, a diagnosis and treatment can take stress to a whole new level. It can feel overwhelming. So with something as life-changing as cancer, we found it useful to kind of take a step back and look at stress that they're facing in another way. So to understand our reactions to how we cope with stress, we refer to a general adaptation syndrome by Hans Selye. It's a simple but elegant model just helping us understand how our emotions, thoughts, and body respond to stress. It has a 3-phase approach to the alleged effects of stress on our body. He was a physician and an endocrinologist, and his work is widely accepted by scientists today all over the world. So he describes stress as not just a one-time only event. And as the father of stress research, he's broken it into 3 stages of alarm, resistance, and exhaustion. So you'll probably all pretty much identify with this. The first reaction to stress is the alarm stage. That is when we recognize there's a danger and we're prepared to deal with that threat. So it's like that fight or flight response. Activation of the nervous system and adrenal glands take place here, and during this phase, the main stress hormones provide us instant energy. So the second phase that we move into is resistance stage. So we have just natural resistors in our body. These are our inner resources that help us respond to difficult circumstances. So stress hormones actually, resolve themselves. If you think about when you were diagnosed with cancer or a patient is diagnosed, how that fight or flight response, that alarm stage really goes into effect. If you let a day or two pass, you might notice that that fight or flight feeling, that numbing, that heart racing, that the numbness that your mind goes through may subside a little, and that is the resistance stage where our body just naturally gets us back, has its own defenses, and gets us back to our natural state. In a stressful condition, though, if it persists, our body adapts to the continued effort in resisting and remains in a state of arousal. So problems begin to manifest when you find yourself repeating this process too often with little or no recovery. So ultimately, this moves you into a final stage, which is exhaustion. So everybody can probably understand what happens during this exhaustion phase. The stress has continued for some time, and your body's ability to resist is lost. So here is where the stress levels go up and stay up. So the adaptation process is over, and not surprisingly, this state of the general adaptation syndrome is the most hazardous to our health. Chronic stress can damage nerve cells and tissues and organs. So why are we talking about all of this? The reason I wanted to take you through that just real quickly is because it's really the science that all of this is based on. There are limits to how much resistance to stress any of us have. So that brings us to the first slide, which really takes us from the first slide, from cancer to health. And the first question that was asked in this research was, could a psychological intervention designed to reduce stress, enhance quality of life, and improve health behaviors and treatment compliance reduce the risk for breast cancer recurrence? So the question was, could this intervention do more than the basics? So the basics that may involve support groups or just emotional support in general. Could this have a biological impact? The trial started in mid-90s. And in 1995, this was a novel question. It takes time, though, to fully understand the impact of the intervention and what the impact is for patients. So we now have the long-term data to speak to this. So this is the conceptual model used to design the clinical trial and test the hypothesis that I just read. Could this psychological intervention impact the disease outcome? The training institute that I went to and the psychology from it, it was based off the intervention developers thought that they could reduce stress and impact the quality of life in a positive way. But they really wanted a bigger picture view to see if that stress reduction and quality of life enhancement could impact other areas. For example, could we get patients to be more compliant? Could we impact actual health behaviors like diet and exercise? And could all of that actually impact their immune functions? So it was through these pathways that they hypothesized the potential impact on the disease course. So this next slide is really quite an eye chart, isn't it? It's the negative relationship between stress and cellular immunity. So by the mid-1990s, data from non-cancer samples suggested that there was an inverse relationship between stress and immunity. So higher levels of stress are related to lower levels of immunity. This relationship was tested in 110 breast cancer patients who completed a self-report measure of stress about cancer in the days following their surgery and prior to their chemotherapy. The data reliably confirmed that the stress of a cancer diagnosis was indeed related to the disruption of cellular immune processes. So you can see here, when cancer stress equals 10, the natural killer cell killing is 60, is higher to the left. And in contrast, when cancer stress is higher, so at its worst, at 60, the cell killing is lower, between 20 and 40. These data suggested that if stress could be lowered, then immunity might be altered or improved. So we conducted a randomized trial. Breast cancer patients were chosen to answer the research question. We needed a homogeneous group. So patients, just for the research purposes, we needed a homogeneous group. Patients were stage 2 or 3 breast cancer patients. They were accrued, assessed, and randomized following surgery, but prior to any therapy beyond surgery. Stage 1 patients could choose to be there, could be part of this if they were distressed. Stage 4 patients weren't included in this group as they have a different set of challenges. After patients were assessed, we broke them into an intervention group and an assessment-only group. The intervention group had 2 phases to it. There was an 18-week, 1.5-hour intensive session followed by an 8-month maintenance sessions. So that 18-week, a little over 4 months, and then 8 months once a month. The intervention happened between assessment from the time they were assessed to 4 months out. The maintenance sessions happened between 4 months and 12 months. The blood draws were conducted in the morning, had specific time windows to minimize the diurnal variability, so took into consideration the hormone fluctuation. What was unique about the trial is that we had continuous follow-up. So following the 12 months, patients were continually monitored for 15 years. This becomes kind of important later when we talk about the survival plots. So here are the 5 major components of the intervention. So the stress and emotional adjustment. So at the beginning, the patients are given the rationale for the intervention. There's a progressive muscle relaxation that happens during every session. And problem solving and positive coping is something that is a skill that is taught early on and used throughout the intervention. The social adjustment is something that everybody seems to get something out of. So it's identifying the support that you have in place today and maybe identifying people that you hadn't thought of yet, but whether they're task or emotional oriented, whether it's positive or negative. And also part of this was in assertive communication, so teaching some skill training around speaking assertively to people you need help from. The breast component, because this in the research was breast cancer, the breast component then had the sexuality and menopausal change information in it, so any of the sexual dysfunction coming from the treatment, and body acceptance or the body image changes, and then communicating with your partner about your own sexual needs. The health behaviors, as you would expect, involve diet and exercise, a walking program, and then, of course, the smoking cessation. Compliance was something that was added on, and this had to do with information seeking around the treatment, working with patients to find good information out on the internet, which is sometimes difficult for patients to do. And also what was added to this was speaking to your provider. So how to have, not necessarily assertive communication, but it could be considered assertive communication. So how do you approach your provider with your concerns? Not something that was addressed early in the 90s. So then the goals of the intervention, these are the clinical goals. The research goal was to have a powerful intervention that would result in strong intervention effects to provide for a fair test of disease endpoint hypothesis. So each goal maps out to each one of the boxes you saw earlier in the conceptual model. So understand the nature of one's own cancer stress, the psychological, the behavioral, and the physiological aspects. Learn multiple ways to reduce daily stresses and improve quality of life, and improve one's current social relationships by communicating directly or assertively to get needs for emotional and tangible support met. Maintain adherence to cancer treatments and follow-up cancer care, communicate one's needs directly and effectively to medical care providers, and improve health behaviors, reduce negative behaviors like the smoking, and increase positive, which would be the healthy diet and activity. Learn tangible ways to reduce symptoms, facilitate recovery, and improve health. So the picture you see there, this was the first group, so in some ways you can tell by the styles that this is early on. Patients met in groups of 8 to 12 individuals with 1 to 2 therapists. One of them is fine, just 2 actually helps with if you have a larger group of 12. The pink notebooks are the patient guidebooks. But now those guidebooks look like this. So there's a guidebook for the therapist and one for the patient. This is a manualized treatment providing session-by-session guidance for the therapist and companion information and worksheets for patients. There's an outline and a goal for each session. Unlike a support group, the intervention is very directive. This is teaching skills, of course done in a real supportive environment. Patients walk out each week having learned a new skill. So when asked about the important group experiences, patients reported that getting information and actually changing their attitudes and behaviors was rated as highly, actually higher, than receiving support from the group. So it wasn't just the skills taught. It wasn't just the skills that were taught, but the environment that it was taught in a supportive environment. So this illustrates just how important it is to give patients meaningful, tangible, and effective ways to cope with the daily stresses of cancer. Support alone just isn't sufficient enough. Okay, so now I'll summarize some of the significant intervention effects. In all cases, the differences you are seeing will be significant. What we measured is always on the left-hand side of the slide, so what you're looking at now is anxiety. The intervention arm is the green bar, and the control assessment only arm is the red bar. Less is better on this slide. Anxiety is going down for the intervention arm. This was taken 4 months after the diagnosis. So the natural course of things, how you would just naturally respond, is the assessment arm. So anxiety does reduce on its own in the assessment arm, just more in the intervention arm. Keep that thought in mind as we go through the results. So the citations will be listed at the end, and these results were published in the Journal of Clinical Oncology with a follow-up paper in Brain Behavior and Immunity. So support from the patient's family increases. So higher is better here. So analysis of the data demonstrated a significant two-way interaction for social adjustment. The assessment arm were likely encountering negative messages about cancer, someone who doesn't know how to talk to you possibly. For example, you really need to stay positive, or don't be stressed. People in the intervention arm also get this from outside sources, but are learning skills to deal with it. So people mean well, but sometimes people aren't good at giving support. So follow-up analysis revealed a significant two-way interaction for the patient perceived support. So perceived support from family significantly increased in the intervention arm, but decreased in the assessment arm. So the next slide is in relation to health behaviors regarding smoking. So as you could imagine, there was a reduction in the number of smokers. Pretty straightforward. And those that continued to smoke, even those who continued, they smoked less cigarettes per day. So the patients reported dietary improvements, such as increased avoidance of the fatty foods. So patients were able to improve their dietary habits during an extremely stressful period of time, many going through chemo. So we were able to get women to make very positive changes at a time that was extremely stressful. So the toxicities from cancer treatment, symptoms and signs were assessed by nurse practitioners who conducted a clinical interview. These were nurse-rated interview measures, not self-report. And now we get to the immunity piece. So this is a standard laboratory immune assay, assesses that the amount of T-cell division and replication when stimulated with a mitogen con A. Assessment arm is what normally happens with the natural course of things. The T-cell blastogenesis is decreasing. In the intervention arm, we saw an increase in the T-cell blastogenesis, an enhancement in immune function. With a similar T-cell, say the effect was the same with the significant declines for the assessment arm only. Cells were stimulated PHA. The assessment is the natural course. The intervention arm, there is virtually no change. It didn't decline. We were able to prevent decline. So the assessment follow-ups continued for 10 years. So let's talk about the long-term impact. Following the first 12-month period when the intervention was delivered, patients were continually monitored on the outcomes just displayed, as well as disease recurrence status. Women were out 15-plus years, continually monitored on all outcomes as well as disease. So this is a Kaplan-Meier survival plot. After the median of 11.5 years of follow-up, these endpoint data for the outcome risk for breast cancer recurrence is shown. After the first 2 years, there is roughly a 10% difference between the arms in risk for occurrence. Survival plot tells you survival doesn't mean living necessarily. It means you don't have a recurrence. It's plotting recurrence status. If a patient doesn't have recurrence, they're plotted. This is a snapshot in 2007 where everyone was that had been through the trial. So the next slide is a 56% reduced risk of breast cancer death for the intervention arm. So while this wasn't predicted as an endpoint, similar effects were observed for breast cancer death at 11 and a half years. And this truly is survival. Not predicted, but significant. We continued to follow people after recurrence, and an unexpected finding was observed. Observed was a significant reduction in risk for breast cancer death for the intervention arm. These were published after the 2008 paper, published in 2010. Analysis showed that the median time to death was 3.2 years for the intervention arm and 1.7 years for the assessment-only arm. These data essentially show a doubling of time to the endpoint, a standard median time metric in clinical trials to indicate that one therapy results in a clinically important improvement over another, basically doubling a person's lifespan. If it recurred, people died. So here's the summary. The biobehavioral model guided design and the conduct for the breast cancer patients. The cancer to health produced multiple improvements, psychological, social, healthy behaviors, and health. And after 11 years of follow-up, analysis showed reduced risk of breast cancer recurrence. If patients recurred, there was a reduced risk of breast cancer death. The biobehavioral intervention has profound long-term positive psychological and health effects. Well, that was all a mouthful. Here is the grant funding. So it's funded through the National Cancer Institute and the American Cancer Society. Dr. Anderson, Barbara Anderson, is the lead scientist in this ongoing research. And here are the primary papers associated. Well, I feel like that was done in record time, so I bet we have some questions. Allie, do you want to open it up?
Yeah, Erin, do you want to talk a little bit about kind of how the Institute works and having people licensed and certified to conduct the program and all of those kind of logistics?
Yep. So the Institute received funding to do this research and to put on this training for people to get licensed to give the training. So it's all copyrighted material, and you have to be certified to do it. And you can apply for the Training Institute. They put on 2 training programs a year. The next one you could apply for will happen in August. It's a 3-day intensive training, a lot of role playing, a lot of hands-on with the worksheets, with the exercises that you work with patients on in each session. Great training, actually. And the training I went to happened last August, and I think there were 40 people in our group, which was rather large. They combined two into one, I think. So they are taking applications for that training now. And I believe they have funding through 2016 to do this. And I'm happy to talk to anybody about, what you need to apply and anything more about the specifics of the training. It all happens on Ohio State campus, where the scientists are located.
So Erin, our first question is there anyone in Iowa already trained in using it with any groups?
So already in Iowa, there are 2 people trained, myself, and boy, I should have, it's on the website. All the people that are qualified to give this program is part of the Cancer to Health website. If you go under the patient section and find a therapist, there is a therapist, and I don't know why her name is escaping me, Lynn, through Mercy in Des Moines, and I can't say her last name because that's escaping me too, and myself in the Cedar Rapids, Iowa City area. Now, the training that is listed here, though, everything I just walked you through was the way that the research was conducted. It was a program that was done in person. There are ways, though, that would still have an impact. They are looking at research around what is the significant impact, how does it change if you didn't do an in-person group, you did one by phone or through Skyping, and that is something that I had offered to Allie, that because in rural places around Iowa or just places that aren't close to Iowa City and Cedar Rapids, I really think this is a program every patient, a critical resource that every patient should be able to be a part of, that as a pilot to test that hypothesis that it will have a great impact, that I would be willing to accrue patients from around the state and form a group that we would get our own clinical outcomes of how we do, how that group does on the phone or through a webinar or Skype. Did that answer the question? Yes, Vestal, Lynn Vestal. Thank you, Crystal.
Erin, one other thing would be, so the research was done with breast cancer patients, but can the program be done with any cancer?
Yeah, good question. So the breast cancer, the reason that it was actually started with breast cancer, Dr. Anderson actually did a lot of her work in the 80s at the University of Iowa. So a lot of people in Iowa are very, very familiar with her. But that is, her background is research in breast cancer and some of the impacts of cancer on breast cancer patients. So that's naturally where the science started. All they really needed was a homogeneous group for the research. What we have learned, though, is that this program really transcends beyond just a homogeneous group, that it is appropriate and to be done with any type of cancer, really, and would not have to be done with one gender only. But the research was conducted with breast cancer. Since then, there have been plenty of groups that have been done that were not homogeneous.
All right, other questions for Erin or about the program? Erin, do you want to talk a little bit about the cost of both the Institute and the program?
So what's great about the Institute is that it's free, and they give you a stipend to go. So, I mean, it's all good. I think the stipend was like $250 travel voucher, depending on how far away you're coming from. So you stay in a hotel either at Ohio State or really close to it. So they feed you, and so everything about the Institute is free. In terms of the program, so the program can be offered a number of different ways. And so for a facility that would like to have a customized program for their own patients done and have research, they can actually publish the research that comes from it. That we can price out just depending on how the facility wants to do it. I do this program with individuals right now. We don't have a formal group going, but what I'm offering the Iowa Cancer Consortium to get actually the word out there and as a pilot is to do it at no charge except for the cost of the manuals. The cost of the manuals are quite large. The cost of the manuals at one time, so I'll see if that has changed, were $35 and then just the shipping cost. So a very nominal amount for a patient that you think is in distress that would benefit from the program to get started on this. Did that answer it, Allie, or do you want me to go into more detail on the services?
No, I think that answered my question at least.
Okay.
If anybody wants any more detail, you can certainly ask for it using the chat tool.
Yeah, and if anyone would like to get a hold of me just to talk further about doing a specific type of program or pieces of the program, so there is a little bit more going on within the Institute in terms of looking at condensing the program. So one of the things that cancer facilities, that kind of the first challenge they have is, oh my gosh, how are we going to get patients to this weekly program? So it really does take, because this isn't a support group, it's far beyond a support group, it really does take the buy-in of a medical team to believe that this is part of the treatment process. This is part of a patient's treatment. It's as necessary as any other part of their treatment. Without that attitude, it will possibly be seen as, if it's seen as by the medical team as a support group, might not seem as necessary to a patient. That's why I think it's important to talk to the patient so that they can see the research around what this is based on, that this really can make a difference in their recovery. So depending on the facility, so that's kind of the first challenge that people have is how do we get people there every week? And how do we do that for, a period of 18 weeks? They've got, patients have so many stressors going on during this time. How do we get them back to the hospital? In some cases, how do we get, the parking, the whole thing? So we're looking at also, and there are some, the Institute's looking at it, and there are some facilities that are actually talking about, could we do like a 9-session? Could we do, if we had to, what would we do if we only could do 8 sessions? What would we drop, or what would we condense? How would we do that? So I'm working on a couple of different models, actually, of how this could be done differently so that it doesn't have to be done in an 18-week program, because it really is the number one challenge that people have is the length of the program. However, so there's 2 phases, remember. There's the weekly sessions, and then after the initial sessions are over, there is a maintenance phase, and that maintenance phase is really as important, we have found, as the individual sessions. And during the maintenance phase, people really do kind of feel accountable to their own goals that they've set, and by then to each other. But the maintenance once a month for 8 months would most likely stay that way, and then people come as they can, but by then probably pretty much a believer that this is making a difference to them.
So Erin, just to continue with kind of what you've already been talking about, we have a question. Erin, have you used this with patients and how has it been received?
Yeah, so beginning to end, no. So I don't have a group that I can say from that we started at the beginning and learned progressive muscle relaxation and then ended with and we're in maintenance. No, I have individually used the program, though, with just individuals, but it hasn't been, so the individuals I work with sometimes are at, all sorts of stages. And the real key to this is when the stress is at its greatest is where they are trying to impact with this program. So after you've been diagnosed and the initial surgery is over is really the best time. So for the research, they of course wanted it to be practical too. That would be naturally what you'd think to be a good time to start a program. For my purposes, though, there are individual, in each session, there are individual worksheets, there are individual exercises that are done because each session teaches a new skill, has an activity to it, an exercise to it, maybe even a little light homework, nothing too stressful, but something that really engages the patients and also always the progressive muscle relaxation. So each session is designed to teach something, and each one then is different. So of those, the cancer, each component that we went through, there were 5 components. Each session has one of those components as part of it. So with the patients I work with now, they could be at any. A lot of them are actually into survivorship. So I have a very specialized focus also on sexual dysfunction in cancer patients. So oftentimes, people probably know me more for that than for this. So oftentimes, I'm brought in from a facility that realizes that a patient into survivorship is having issues but hasn't talked to the medical team about it. The medical team hasn't talked to them about it. They just find out through either maybe a survey, a distress tool, or through one of the nurses that a patient felt comfortable with that they're having issues sexually. So that's when I oftentimes get brought in. Amazingly, though, these exercises, these individual exercises, actually still work for those patients. There still is a high level of stress into survivorship. But the goal would be to catch that long before survivorship, to get it into the treatment stage. And I have not put a group together that has done that.
But for the most part, you would say that the patients you've worked with have found the components of the program very valuable.
Absolutely.
All right. The next question is, what is the data collection requirements for those who train and provide this?
Yeah, so depending on if you go through, I think most people have to go through their own IRB to, if your facility, if your hospital needs to go through the review board and have this approved, which most do because this is data about patients, then you'd go through your own rules and regulations around publishing that research. If you don't have your own institutional review board and want to be part of the research that Ohio State is, you can be a part of their review board. You just have to follow their rules, all of the criteria around what you need to do. So it's pretty strict to make sure that the data is actually good data. They set up with the sessions that you need to do. You can adapt slightly, but we would have to go through Ohio State and adhere to their criteria if you wanted to publish the results. Of course, you could put this program on and have your own clinical outcomes if you were trained to do it, or have me do it, and you could not care about the research associated with it because you aren't planning to research or to publish your own findings. You can do it either way.
All right, the next question is how do patients pay for this? Some of us do not have mental health compensation on our insurance plans.
Yep, it's a real, so my goal is, so just so the patients that are on the phone know this, my goal is that patients wouldn't be paying for this, that the institutions would be paying for this. There would be sponsors that would provide the funding for it. I think it's a mistake for individual cancer centers and hospitals not to. I think it's a mistake not to. So I feel very strongly about that. However, based on what Allie and I have said just earlier, that because we do believe it's such a critical resource, and me specifically believe it needs to be out to patients around the state of Iowa and that it can impact their recovery, I'm willing to put a group together to do this on the phone as opposed to in person. So if we had a group up in Spencer, Iowa or whatever, and I couldn't be there to put it on every time, we could have a program where there are patients across the state that are part of a group, and we do the group. Maybe we're meeting on a weekly basis. I have to accrue everybody to make get the assessments done with whoever, what patients would want to be involved. But I'm willing to give the time at no charge to the patients that are coming through the Iowa Cancer Consortium for this. So I'm doing some testing myself in doing this to make sure that the outcomes of this, that the impact to the patient not in person can be as significant as they are in the in-person support groups. So if that was a roundabout way of saying, I'm not going to charge you anything except the cost of the books if you want to be involved in a program.
All right, do we have additional questions? I've heard Erin talk about this program 3 or 4 times, and I think the outcomes that it produces are just incredible for all of these cancer patients. So I'm glad that she had an opportunity to talk with all of you today.
Thank you, Allie, for having me speak to everybody. I'm thrilled that we're getting the word out, that there is a program out there like this. There's never been a program like this in the past. I wish there had been when I was going through it myself. And I hope that it's of interest to your participants on the phone.
Right. Well, thank you very much to all of our participants, and I don't see any more questions coming in. So thank you again to Erin, and thank you for all of you who have joined us, and I hope you guys have a good afternoon.
Yes, thank you very much.